Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video using the iClearScope endoscope. And here we have quite an emotional procedure. It's of a patient aged 85 and they suffer from Alzheimer's. And so their ability to communicate is already somewhat affected. However, that was worsened in the last couple of weeks because of their bilateral earwax impaction, which meant that this patient wasn't able to hear anyone at all, and it really isolated the patient, and it also naturally concerned the patient's children who both attended at the appointment. They were increasingly getting worried because the patient wasn't responding, and at one stage they assumed that the Alzheimer's may have worsened. And just seeing the difference in this patient upon attending and upon leaving, it's quite heartwarming actually. The patient themselves was quite emotional, and it was instant. As soon as we removed the wax, he was able to converse with his son and daughter. It was a very tricky case. This patient previously attended a couple of years ago, and after today's procedure I've recommended that they come on a yearly basis because it was extremely occluding and impacted earwax. And this is their right ear. The left ear was actually more tricky, and I'm just performing microsuction here, and they've got a few matted hairs. And the consistency of this wax is that type of consistency. It's hard to suction, it's hard to use ENT micro instruments. For example, if I use an ear hook, it's just going to dissect through this. Similarly, we can't use forceps, the wax is just too soft. Even with a correct, which I think I did use, I got parts of this wax out, but because it was so soft, it was smearing the rest against the canal wall. They also got quite a narrow entrance to the ear canal and quite a bendy ear canal as we dwelled deeper towards the eardrum, so it was quite challenging. In the left side there was some residual wax, a spoiler alert. There was some wax left in the anterior recess, and you'll see I really attempted to remove that, but they've got quite a prominent anterior recess, and even despite bending the fine end, it was so difficult getting access into that recess. So we left that. The patient could hear perfectly fine. The wax appeared to be just off the eardrum, so it wasn't affecting the hearing. And we're hoping now that we got the remaining blockage out, that residual wax will naturally migrate outwards as wax should do. Now I'm using the correct here, and as I described earlier, I was able to get parts of this wax out, but at the same time I was spreading some of this across the floor of the ear canal, as you can see there. So you can see it extends right from the entrance. So this is just past the first bend, and in the distance you can see the wax plug filling up the medial part of the ear canal, so the deeper regions. And because I smeared it at the bottom, I'm just going to the floor of the ear canal, trying to lift this away. We have put some medical grade olive oil drops in there. You can probably see that resting at the floor. And because it's quite sticky, it's up against the canal wall, it's enveloped in some dead skin as well, which we're trying to lift away. The wax is quite dark, so we know it's oxidized. It's been there for a while. And I think this patient returning on a yearly basis is going to be the best thing for them. So because they have got quite a narrow bendy ear canal entrance, you may have seen there, I just used my thumb and finger to pull the patient's ear back and up. So in adults, by pulling the ear back, so posteriorly, and then up superiorly, not only are you stretching open the entrance of the ear canal, but you're straightening the ear canal somewhat, and that allows us to then enter with the microsuction tip here. So if this wax was a bit firmer, it'd be a bit easier to get a suction grip, but it's just got this soft caramel or fudge-like consistency. And you can see I'm trying to lift this off the canal wall, trying to separate it. So the posterior canal wall is slowly revealing itself. It's just blocked the suction tip there, so I've just come out. So if the suction tip gets blocked, we've got a threader, and we just thread it through. So it's a cleaning rod. We thread it through the inside of the suction tip, and it just unclogs any blockages. Some people use water, so they get a cup of water and they put the suction tip into the water. I try and avoid that because the water is then being suctioned up the hose pipe, and it's collecting in the canister that we've got, and it can start getting a bit odorous over the course of the clinic. So I prefer not having any water in the canister, and it's sometimes a bit difficult to dispose of the canister because it's got fluid in, and as you're walking around, depending upon how much water obviously you use to unblock the suction tip. But if you've got 4 or 5 patients and consecutively you're having to use water, that canister can get full of fluid. Now there's special canisters which have additives already inside, or you can add it yourself, which tries to solidify any wet matter, so it makes it into a gel consistency, so it's easy to dispose of. But I think the cleaning rod works fine. So I'm just trying to pull this wax away from the front part of the ear canal, and there is a bit of a widening here, so this wax has entered into a widening, so I'm just trying to pull that away. You can see the periphery, you've got this layer of adhesive skin that's enveloped the wax plug, but it is also semi-attached to the ear canal wall as well. So this skin layer is a lot thicker at the top, the roof of the ear canal. And slowly in the distance, I can feel this now separating from the patient's medial ear canal and the eardrum also. Again, I'm going to just dilate the ear canal open. So we brought this right near to the entrance. I'm just going to wriggle this through. So when you're wriggling it through, you need to be able to navigate around the bends of the ear canal. And I'm just using this rocking motion, which helps to drag it forwards. And we're nearly there. And see some of those hairs that are matted up against this wax, which does make it a bit more difficult to obtain an airtight seal to increase the suction power. And because this part of the ear is quite narrow, it's getting trapped as we're bringing it through. So this plug is physically larger than this region of the ear canal. So in the midsection of the ear canal, in particular, the ear canal is at its widest point. So that's where some of the wax can form. And as you're bringing it out through the entrance, the narrowest part can be tricky. And you can see that some of that skin just came away. And it is just trapped. Sometimes I joke with patients that it's almost like giving birth. We're having to pull this wax plug through. And sometimes you have to orientate the wax into certain angles, or flip it over, or kind of roll it out. So it really is playing hard to get this, but we're getting there. I think I've just managed to free this. So I'm going to re-enter the ear. Eardrum's nice and healthy. It's a peripheral skin. It's going to mop this entrance up. And yeah, we're really pleased with that. And so was the patient and his family who are in attendance. So the eardrum looks nice and healthy. And this is the more difficult ear, actually. In fact, when the patient attended, I started off with this procedure, this ear. Now, it may not look as much wax in comparison to the right, but this was really impacted against the eardrums. It's a bit deeper. And they had been using some softening drops prior to attending. You can see this more lateral wax is already wet and very gooey. So we're going to clear this first. And again, I'm lifting up and away to separate it from the floor of the ear canal, and then from the front part of the ear canal, I'm bringing the wax inwards to loosen it. Fortunately, the patient was really still for me, and very cooperative. And you've got patients sometimes with Alzheimer's, it's kind of sometimes can be difficult keeping them still. So we just kind of accommodate that. So whenever the patient moves, we just try to, and that's what's great about the eye clear scope and the wax scope. When we're performing the procedure, even if we're not directly looking at the patient, at the periphery of our vision, we've got kind of an eye on the patient, even if it's subconscious. So any slight discomfort the patient may encounter, we can actually visualize that. If you're using a microscope or head loops, you've got goggles in front of you, like binoculars, so all you can see is into these binoculars and goggles. You can't see the patient and their body reactions, which I think is really useful and helpful when removing earwax. So they've got this thick layer of skin, it's quite crusted, so I put some medical grade olive oil And we're going to try and separate this, and by separating it, hopefully it will loosen up the wax plug. So you can see the skin extends all the way down the front part of the ear canal towards the eardrum. And similarly to their right ear, the wax is really dark in colour, so we know it's been there for a while. So then I'm going to go to the floor of the ear canal, trying to lift this up. So this part of the wax is a bit more stubborn, a bit more adherent. You see, it's got this very glossy appearance, which means there's a lot of skin content. Dead skin contains keratin, which is a protein found in our fingernails and hairs as well, and it's highly reflective. So when you get this glossy appearance, it just means it's got high keratin, dead skin content. We can see that here. You can see how thick this layer of skin is at the floor of the ear canal. We're just trying to lift it up and away. There's some oil I've put in already, so as we're lifting it, the oil's actually going, passing through and going deeper, which is going to also help lubricate the medial ear canal wall. So we're probably 2/3 of the way in now. And this has just got a bit more stodgy. I think that's probably the best way I can describe it. So it's a bit more harder to vacuum. But this ear canal, and you can't see at the moment, when you enter it, it veers off. So if you're looking on screen, I've got to do it the other way. It's going to veer off almost like a 45-degree bend, probably not as much as 45 degrees, probably 30 or 35 degrees, but it really veers off and the wax is trapped in that bend. So it's lodged very deep in the ear. So I'm just going back for that layer of skin at the front and then back to the floor. And they've got kind of a steep valley at the floor of the ear canals also. I'm just trying to wriggle it and bring it up at the same time out of that valley. You can see I'm angling this plug upwards to release it. You can just see how compressed that wax is deeper in the ear. So I don't know, I did ask the patient and the family members whether they did use any Q-tip or cotton bud in this ear, and they said no. So, but it was really, as I said, it's pushed in or impacted. And I'm just trying to drag it down now from the top, so I've got a better suction grip here compared to where I was suctioning before, where it's quite stodgy. The surface, the top of this wax plug is a bit drier now. I tried to go in with the ear hook, but because of the angulation, it was hard because this patient's got quite a bendy ear canal. So I just came back out, and this is where I used the ear pick. The ear picks, because it's low profile, it hasn't got that 90-degree bend. I was able to go over the top. Now, although the ear pick didn't remove this plug, it did break it up. So you can see we managed to get in really deep with that. And sometimes that's all you need with the manual instruments. You just need it to break it up, and then you can go back in with the suction to clear up all the debris. So I've released that more lateral section of the plug. We're going to go back in with the microsuction now. And I'm just going to wriggle this out and it should break away. There we are. So I've now separated it and we're going to come out the ear. And we've just got this last, I was hoping that this wouldn't be as impacted, but it's lodged beyond the isthmus. So as we approach the eardrum, the ear canal narrows and then it widens again. And this soft wax is beyond that narrowing. You can see it's just blocked the suction tip there. So I am going to put some more oil in. You can see it there. And I'm actually vacuuming whilst the oil's in. With this type of wax, I prefer to keep the oil in situ. So I've just got the patient's head tilted over so the oil doesn't drizzle out. And I'm actually standing up at this point. So I'm looking down into the ear. So finally, we can see some of the patient's eardrum. We can see the posterior quadrant. And already this patient could hear so much better from this ear. He actually asked what that noise was. So we've got a suction machine. It wasn't the suction noise with the sucker in the ear, but the pump, external pump. And the patient wasn't able to hear that upon attending. As soon as because the pump was more on this patient's left side, and he says, what was that noise? And we're trying to figure it out. And I said, it's probably the suction pump. So I switched it off, and the patient goes, oh yeah, it's disappeared now. So, and that pump is quite noisy externally. You can just imagine how blocked this patient's ear is. So I'm just using the fine end because this patient's ear is quite narrow here, and we're working close to the eardrum, but the fine end wasn't actually powerful enough. But we're going to continue because I couldn't get the zone to the lower parts anyway. And there's some skin here. We're going to try and peel it up and away if I can. I'm not sure if I'm able to. We shall see. The skin just wants to flex back down, so but managed to peel it up. Now, this is a good example where you kind of quick whilst you're ahead. The patient can hear, yes, there was some residual wax. No, I don't want to put any water in this patient's ear to kind of remove that last bit. I'd rather this patient have a little bit of wax and it's not affecting their hearing than attempt to remove it with water, because I'm not the biggest fan of water in the ear. And some of you may, or a lot of you may already know that. And so to say that other people want to use water, that's fine. But for me, I just don't like the concept of water in the ear because it can, not for everyone as well. So for 95% of the population, you'll probably be fine. But who am I to predict who's the 5% that may potentially have an infection? With elderly patients as well, or patients who are diabetic or immunocompromised, you want to stay away from water as well as part of the guidelines. We have some guidelines, the NICE guidelines, the National Institute of Clinical Excellence, which reading through these guidelines a while back, they actually promote the use of patients self-irrigating using a DIY bulb syringe, which makes me kind of question whether or not I should be kind of, and we should as healthcare professionals be following or making reference to these guidelines. But I was just gobsmacked that the NICE guidelines were recommending GP practices to educate patients how to self-irrigate their ears using a bulb syringe over the counter. It's the world we live in now. We've got any Tom, Dick and Harry performing earwax removal. We've got the guidelines saying this and that, which clearly is not based on clinical evidence when it should be. So we're just trying to release this bit of sticky wax. And as I said, I've bent the tube. You can just see how prominent this bend is, and I'm just so careful. I don't want to make contact with the front part of the ear canal. You can probably see we're so close to that already. But yeah, we can see 4/5 of the eardrum. The hammer bone is fully visible. It may slightly be on top of the drum, but I'm really, really pleased with that. And continuing any more may lead to an infection. And the reason why you want to avoid water in patients who are elderly, immunocompromised, or diabetic, because they're more prone of developing secondary malignant otitis externa post-irrigation. It's a very rare condition, and it's not to say anyone who is elderly, diabetic or immunocompromised will develop malignant otitis externa post-irrigation, but there is a consensus of evidence out there that they are kind of more likely than someone who's not elderly, diabetic or immunocompromised. And so the guidelines there do stipulate, think twice about using water in an elderly patient, which this patient obviously is. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.